My name is Angela Van Sickle, and my presentation is Managing Dysphagia in Dementia Care, Current Practices of Speech-Language Pathologists. I have no disclosures except that I'm employed by Texas Tech University Health Sciences Center in Lubbock, Texas, USA. So a little bit about my journey. Before going back to school to complete a PhD, I worked many years in adult rehab. Some of the facilities I worked in were skilled nursing facilities, so you can imagine I worked with many individuals with dementia. When I finished my PhD and started working in academia and was able to do research, I wanted my research to make a difference in the lives of people, and I chose the population of individuals with dementia because I wanted to be an advocate for them. So the World Health Organization reported that dementia is present in 55 million individuals worldwide, 71 years and older. Approximately 45% of individuals living with dementia who are institutionalized also have dysphagia or swallowing disorders. If you're like me and have worked with many individuals with dementia, you may already know that even in moderate severe stages, many individuals can still follow directions, simple commands, and potentially have the capacity to participate in rehabilitation. But a lot of the literature concerning intervention for dysphagia for individuals with dementia is compensatory rather than rehabilitative. And one of the most common compensatory strategies is to change their diet level. This 1995 study by Brewer and McCabe is a wonderful study. They examined the diet levels of individuals in skilled nursing facilities. And of the 740 charts that they looked at, 212, 28% of the residents received altered diets. Now, of those 212, 112, 58% of those residents had a diagnosis of dementia. And then of those individuals with dementia, 58% received a pureed diet. Not so fun. Now, aside from having dementia or not, one powerful finding from this study was that they went into these facilities and they did swallowing evaluations on these 212 individuals and found that 91% of the participants that were on altered diets were able to consume a higher level diet. So this study in 2020 examined the effects of non-pharmacological treatment on cognitive functions for individuals with dementia. Those treatments included physical exercise, therapeutic role-playing, such as reminiscence therapy, nursing care, such as proper eating and drinking, horticulture therapy, and self-cognitive training like coloring books or crossword puzzles. And they found that during this treatment phase, the pre and post, that these individuals with dementia improved their scores on the mini mental state exam. So they concluded that this provides support for neural changes in individuals with dementia. That is very exciting news to me. Neuroplasticity is believed to underlie relearning achieved through rehabilitation. So, are we rehabilitating swallowing skills for individuals with dementia? And if not, why? This led to this survey-based study aimed to investigate whether practice patterns of speech-language pathologists would differ for an individual with moderate cognitive impairment versus an individual with no documented cognitive impairment. So this is what I saw. This was my experience. I saw a speech-language pathologist treating individuals with dementia differently than they would treat a patient that had a stroke or another event. So two of our questions were, do speech-language pathologists initiate treatment with the same frequency for individuals with versus without a diagnosis of dementia? And then do speech-language pathologists' choices of intervention strategies differ between a case with versus without a dementia diagnosis? So basically, do they pick up these patients with dementia for therapy? And then when they do, what type of strategies, compensatory or rehabilitative, do they choose? So even though over 420 people started the survey, 77 speech-language pathologists completed 90% or more of the survey. And so the results are based on these 77 speech-language pathologists. So they opened the survey and there was a consent page. So if they completed the survey, that was their consent. And then there were demographic questions. And then they read a case history, and watched a modified barium swallow study, and then answered questions about the case. They did that for one case and did the same thing for a second case. The impairments for each case were similar. In fact, both modified barium swallow studies showed aspiration of materials. So they were very similar, and the questions after the cases were identical. But the first case included a diagnosis of dementia, and the second case did not. Those questions after the case, two of those questions required speech-language pathologists to make decisions concerning whether to initiate treatment, and then decisions on which interventions to use in therapy. This is the cross-tabulation table. And so this table shows what the respondents did for the cases together. So what they did for the case with no dementia and what they did for the case with dementia. So in other words, this first cell here with a 2, that tells us that 2 individuals did not initiate treatment with the dementia case and did not initiate treatment with the no dementia case. This cell with 22 shows us that 22 of the people responding to the survey did not initiate treatment with the dementia case and did initiate treatment with the no dementia case. Now, I have these 2 questions in the same table, so you see the compensatory and rehabilitative. This cell shows us that 6 people responding to the survey used compensatory only strategies with the dementia case and compensatory only strategies with the no dementia case. And then 8 individuals responding used compensatory only with the dementia case and rehabilitative strategies only with the no dementia case. So this is the data that was used for the statistical analysis. And you've already probably noticed that the compensatory and rehab part of this table has lower numbers. And that's because this was an open-ended box. And so people could write anything they wanted in there. And we took out all of the strategies and organized them to figure out if they were compensatory or rehabilitative. But many people responding to the survey put compensatory and rehabilitative strategies in the box. And so this table shows only those people that chose compensatory only strategies or rehabilitative only strategies. There was a statistically significant difference in the proportion of individuals who would initiate and would not initiate treatment between the 2 cases. More speech-language pathologists chose to initiate treatment for the case without a dementia diagnosis than the case with a dementia diagnosis. So now this information is just looking at the cases separately, not whether they did this for this case or this for this case. This is just looking at the dementia diagnosis case. 69%, 53 of the 77 SLPs stated they would initiate treatment. So that's good. And 31% chose not to initiate treatment. So that's 69%, that's pretty good. But when you look at it compared to the no dementia case, 94% of the participants stated they would initiate treatment with the no dementia case. And only 6 chose not to. So that's a big difference. Now, when we're talking about intervention strategies they would employ, there was a statistically significant difference in the proportion of individuals who would provide compensatory strategies for the dementia case and rehabilitative strategies for the no dementia case. So compensatory strategies were chosen more often for the case with a dementia diagnosis, and rehabilitative strategies were chosen more often for the case without a dementia diagnosis. Again, looking at each case separately, 25 of the 77 speech-language pathologists, or 32%, used compensatory only strategies with the dementia diagnosis, and only 15% used rehabilitative only with the dementia diagnosis case. Compared to the case with no dementia diagnosis, 16% used compensatory only and 24% used rehabilitative only. Now, other questions, we did look at other things in this survey, and one of those was whether the individuals responding could identify the swallowing impairments in each case. So even though I've put these case by case, this isn't really based on whether there was a dementia diagnosis or not. It's just, were speech-language pathologists able to identify the impairments? And consistent with previous research by Carnaby and Herrenberg and Plowman and Humbert in 2018 and Vos and colleagues in 2018, we found that this was difficult to identify the impairments. So no participants for the dementia case identified all the swallowing impairments, and only one for the no dementia case identified all the swallowing impairments. Now, some were correctly identified, but not all. And that's 18% of the participants identified some, but not all, for the dementia case, and 6.5 identified some, but not all, with the no dementia case. Now, some were correctly identified, some, again, but then added impairments not present. That happened 67% of the time with the dementia case, and 15% of the time with the no dementia case. And then individuals only identifying impairments not present were 7 and 9%, which, thank goodness, that wasn't so high. Okay, so this is the information on what compensatory strategies were chosen between the two cases. And for the case with a dementia diagnosis, participants provided 25 different compensatory strategies, but only 7 of those 25 had the potential to mitigate impairments relevant to the case. Now, for the dementia case, participants provided 16 different compensatory strategies, and actually only half of them had the potential to affect the impairments relevant to the case. This is the table on the rehabilitative strategies. And as you can see here, for the case with dementia, participants provided 16 different rehabilitative strategies, but only 2 of those, and they are marked with an asterisk, only 2 of those had the potential for addressing the identified impairments. Now, for the case without dementia, there were 22 different rehabilitative strategies, and only 9% of those, demonstrated a potential for addressing the identified impairments. So although the impairments were comparable across both cases, participants' treatment decisions in the current study appeared to be influenced by the presence of a dementia diagnosis. Participants were significantly more likely to initiate treatment for the case without a dementia diagnosis. And then compensatory strategies were more frequently recommended for the case involving dementia, whereas rehabilitative strategies were more commonly suggested for the case without dementia. So these findings suggest that speech-language pathologists may demonstrate a bias when a dementia diagnosis is present. And this bias was observed regardless of the experience of the clinician or the educational background. The decision to withhold treatment or not see the person for treatment, or to limit rehabilitative approaches, could negatively impact the health and quality of individuals with dementia. Of course, additional research is needed on the effects of rehabilitative strategies for improving swallowing impairments for individuals with dementia, and I hope that is what happens next. Here are some selected references. And thank you for listening. And I appreciate the invitation to speak at this very important conference.